start, Vijay.
So, welcome to the second session, second in the series of Professor Vishwanathan online education series. This time we have a good speaker on a good subject, and that's type 1 diabetes. And none other than Banshi Sabu will be introduced formally a little later. So we started this online diabetes education program just to uh, take forward the ideas of Professor Vishwanathan during his 100th birth anniversary. So, can we have the first slide CV of Professor A. Ramchandran? The slide. So Professor A. Ramchandran has got tons of experience in type 1 diabetes, and he is a current president of the India Diabetes Research Foundation, IDRF, and is a chairman of the Dr. A. Ramchandran's Diabetes Hospitals in Chennai, India. And he is internationally renowned for his work on epidemiology. And also, last time we discussed at length about the Indian Diabetes Prevention Program and his pioneering work on the use of mobile technology in the primary prevention of diabetes is well known. He has published more than 400 original research papers. Next slide, please. It's also my unique honor to introduce my elder brother, Professor V. Mohan, who is the chairman of Dr. Mohan's Diabetes Specialty Center and Madras Diabetes Research Foundation, Chennai. His main interests are in epidemiology of diabetes and its complications, genomics of diabetes, including monogenic diabetes, and type 1 is his forte, and fibrocalculus pancreatic diabetes, precision diabetes, and nutrition. He has received 200 awards, more than 200 awards, including the prestigious Dr. B.C. Roy National Award by the Medical Council of India, and from ICMR, the B.R. Ambedkar Centenary Award. He received the prestigious Dr. Harold Rifkin Award from the American Diabetes Association in 2018, and he has been conferred the FRS from the Royal Society of Edinburgh. And he has published not less than 1,600 papers, which is a dream for many of us in peer-reviewed journals and textbooks, including 1037 original papers. His research has attracted over 1,89,000 citations and H index of 151, which is making us all proud of him. And he's ranked among the top 2 scientists of the world by Stanford University. And he was rightly awarded the Padma Shri by the Government of India in 2012. If any of you have not read this book, Making Excellence a Habit, published by Penguin India, and Banting Bows and Beyond, I think you should. They're both bestsellers on Amazon, and he'll be happy to send you a signed copy if you wanted it. So on to Professor V. Mohan and then on to Dr.
Thank you. Can I have the slide to introduce Dr. Vijay Vishwanathan also? So Dr. Vijay Vishwanathan is the head and chief diabetologist of the MB Hospital for Diabetes and the Professor M. Vishwanathan Diabetes Research Center, Royapuram in Chennai. We are all, as Indians, very proud that he is the first non-European president of the D-Foot International. For those of you who don't know what is a D-Foot, they have a separate association only for those interested in diabetic foot. And it's very rare for a non-European because it's based in Belgium. And it shows how much credibility he has in that field. And for a 2-year period, he has been elected as the president of the D-Foot International. He is also the past national vice president of RSSDI and recently elected as the president-elect of the RSSDI. He completed his MD in internal medicine. He works and was trained by my father, Professor Vishwanathan, for several years. He has completed over 3 decades as a diabetologist. He was conferred his PhD for his work on diabetic nephropathy, and his other areas of interest are tuberculosis in diabetes, apart from diabetic foot, which is very close to him. He is a recipient of the first Vivian Fonseca Award from the American Diabetes Association for his research paper on diabetes and TB. And as I mentioned, he has a lot of research interests, including prevention of diabetes and its complications, kidney, TB, and diabetes. He has over 300 research publications. Now, we will be, the three of us jointly are conducting a series of programs. And the first one, Dr. Ramchandran and I spoke, and Dr. Vijay Vishwanathan was a moderator. This time we have none other than Dr. Banshi Sabu, who I'll be introducing shortly, to give the talk. And probably we'll have at least one more in this series, which we'll announce later. Now, it gives me great pleasure to introduce our good friend, Dr. Banshi Sabu, who is the Chief Diabetologist and Chairman of the Diabetes Care and Hormone Clinic, Ahmedabad. He is a chair-elect of the IDF Southeast Asia. He is a Vice President of the Diabetes in Asia Study Group. He is Secretary of Diabetes India and the Indian Academy of Diabetes, and he is a past President of RSSDI and the All India Association for Obesity, Advanced Research in Obesity. He is the founder of DTech, Diabetes Care India, Diabetes India Suite Registry, and he is a hub leader for ECHO India at Ahmedabad. He is a managing editor of Sadicott's International Textbook of Diabetes and Diabetes Metabolic Syndrome Clinical Research and Reviews. He is advisory board member of many journals, including JAPI, Journal of Diabetology, JOMR, etc. He has received many fellowships, FACE from USA, FACP from USA, FICN, the Fellowship of the International College of Nutrition, and of course he has received FRCP from Glasgow, Edinburgh, and London. He also has an MNAMS in diabetology. He is an expert in the RSSDA guidelines management of diabetes, ATTD, CGM guidelines, and ISPAD guidelines. He has more than 150 publications in index journals and has contributed to various textbooks and monograms. He has been awarded the most impactful health leader by the World Health and Wellness Congress. He has completed many public awareness programs like RSDA Defeat program, Kadam, IDEA, multiple diabetes clinics along with AMC's support of WDF. His passion actually will come out today when he talks, because that is in the area of childhood diabetes and type 1 diabetes. I know that he treats hundreds of children with type 1 diabetes completely free of cost, and he has been working tirelessly for the cause of type 1 diabetes, making it almost a passion or a movement all over India. I request Dr. Ramchandran also to say a few words about Dr. Banshi Sabu, after which we'll go on to the talk. Over to you, Dr. Ramchandran.
Thank you, Mohan. Banshi, I want to just add a couple of sentences about you. Mr. Mohan has talked about your CV. You can hear me well?
Yeah.
Yes.
Yeah. Okay. As you know, Banshi does not fare in the introduction to the diabetes crowd in India. We also know that he has been the most dynamic organizer for a number of conferences. I think probably by far, as a single person, he has probably organized the largest number of diabetes.
I think Guinness Book of Records. Guinness Book of Records. Yeah.
Now that has resulted, and let's see the impact of this. That has resulted in imparting so much of knowledge regarding diabetes care to thousands of citizens in this country. And what has happened because of that, Banshi, I can tell you, your work and your efforts have resulted in increasing the level of diabetes healthcare in this country, in every part of the country, in every nook and corner. I think that is something which cannot be achieved. I think probably only government can achieve what you have done. So I think that impact has to be recognized by everybody. And I really salute you for the work that you have done so many years. I hope you will continue to do this and enhance your efforts so that the diabetes healthcare delivery will go to higher levels, better standards in our country. So over to you, Banshi. You're going to talk about type 1 diabetes care in this country. And that's your plan. Go ahead.
Sir, first of all, thank you. I'm really, today I feel so proud that, Dr. V. Mohan sir, Dr. Ramchandran and Dr. Vijay Vishwanathan, all three of them are asked me to deliver a talk. And that too, particularly when we are dedicating this to Professor Vishwanathan. And I was fortunate this year that I got the Professor Vishwanathan oration also in RSSDI, and Dr. Vijay was there with us, and I could deliver my talk that 25 years of my journey of diabetes in RSSDA. And then I started with what I was and what I have done. And RSSDA had given me a lot of opportunity. And in that particular talk, I talked about Dr. V. Mohan, that as a youngest person, and I was an executive committee member, he asked me to become the chair of scientific committee in 2012, and he organized a organizing chair of RSSDA. So, and once again, really, sir, I am very much thankful for and grateful to all of you that you considered me as one of the talk which you had asked me to give. What I am going to talk in next 30 minutes, the type 1 diabetes care in our country. So let me share my slides, and I hope that I'm audible and
Yes, you're audible. Slides, yes, slide has come.
yes, sir. And my slides are properly visible also.
Perfect.
Yeah.
Yes, sir. So in next 30 minutes, I'm going to talk about type 1 diabetes care in India. And then we can have definitely the comments from seniors like Dr. V. Mohan Ramchandran and Dr. Vijay Vishwanathan. They have treated thousands of type 1 diabetes and taking care of thousands of children. And across the country, many more seniors and many more consultant diabetologists are actually taking care of these children. I start my talk with this slide that a type 1 child has to survive. To survive, he has to take 1460 shots in a year to stay alive. And this is a Facebook post, which is in a social media. The mother of this child had actually put just to increase the awareness about the type 1 diabetes. And I'm sure this child also has to take more than 1460 pricks per day or maybe more just to keep her sugar checked, also for taking multiple shots of insulin injection. Even this child may not be doing it because she is on a continuous glucose monitoring and pump. But the idea of putting this photo on a social media is to just to increase the awareness. I don't have anything for this particular talk as far as financial conflict is concerned, none, except that I have a passion for this particular topic. Let me start with this slide that in 2021, this data of International Diabetic Federation is talking about disproportionate medical burden of type 1 diabetes. And we know that by country, India now has the highest estimated number of prevalent type 1 diabetes cases in people under 20 years of age. And this, many of our colleagues, many of physicians, many of pediatricians, and many of primary care physicians, they don't know that we are having highest number of type 1 in the world. Second in the type 2 diabetes after the China. But for type 1, we are having highest one, that is 229,400. And this is International Diabetic Federation data of 2021. After which we have USA, which is second highest, and Brazil. Now this is below the age of 20. We don't have the longitudinal data that how many of them are surviving and how many of type 1 adults we have in our country. If I go with the data of IDF 2021, as I told you that we have highest number of type 1 diabetes below the age of 20, that is 0 to 19 years in our country, that is 229,400 children, or below the age of 19. But if you see the number of new cases, so it means not only we are going to have 229, which is highest, but every year 24,000 young, these children are again added, and that is also highest in the world. So I mean, again, we are going to have highest number of these type 1 children who will be added in this list. Now the last, this table, you will be surprised to know that incidence wise, we are not even in the top 10 countries. So incidence rate of per 100,000 population per annum for type 1 diabetes in children, we are not in top 10 countries of the world. So if you see, Finland is the highest one, Ireland. So probably after 25 or 30, we may have the list for that. Now, where are these children are disappearing? And that's a very big question. And why we all adult physicians, all adult diabetologists are working so hard, because we are suspecting that these many children, since years we are thinking they are actually dying before, either before the diagnosis or many of them soon after the diagnosis. If we take the extrapolating the data, the prevalence of these 0.54 per 1,000 population, in Indians who are in UK staying, probably this list will not be just 229,000, we will have 9 lakh children in a population of 140 crores, assuming all type 1 diabetic patients are diagnosed and they all survive. But most, they don't live long enough to get counted. Due to this heavy burden imposed by this type 2 diabetes epidemic, we have running with this pandemic of type 2 diabetes. This type 1 diabetes has been overlooked with terrible consequences for these children. So now across the country, you talk to any minister, any IAS officer, any administrator, many of them, they understand that diabetes is very problematic in our country. Even many times the media people also write, when we ask them to talk about type 1 diabetes, they talk about type 2 diabetes because it's a epidemic where millions of people are suffering from type 2 diabetes, and that's the reason the type 1 diabetes has been overlooked. But still, the type 1 incidence in our country is also increasing slowly by 3 to 5% per year because of more autoimmune disease which we are having. Now, today I will be talking about very interesting paper, which is type 1 diabetes index, which I'm sure Dr. Mohan sir and many of you know about it. This was a paper which was published with the support of Juvenile Diabetic Research Foundation, and they had talked about the global incidence, prevalence, and mortality of type 1 diabetes in 2021, and then they have projected it for 2040. According to this paper, the India should have the persons with type 1 diabetes around 8,60,423. So they have just calculated that this data is not just 2,29,000 of below the age of 19, but there are many adults and there are some of them who are surviving enough up to the age of 30 and 40. Probably we have these many people who are in India who are having type 1 diabetes. But what they have written, that we have population which is lost due to type 1 diabetes in India is not just 8,60,000. We have 9 lakh people. We lost them in last 20 years. They have been diagnosed as a type 1 diabetes, but they could not survive for 20 years or maybe 30 years. And that's the reason we lost them. The new persons in India is not just 24,000 children which are added in this list. We have probably 85,770. These type 1 maybe young adults, maybe children, or maybe some of them adults who are added in this list. Now, this is one very important point also, people with comprehensive care. And in this paper, they talk that in comprehensive care, which is talking about the sensor augmented pump therapy or something which is advanced therapy, which we could afford or which we could not afford. So very few people in India are actually on these people with comprehensive care. Some of patients which recently published, I talking about Dr. V. Mohan paper of this advanced hybrid closed loop therapy, which we had given with some of patients, but they are very, very few. And in 2021, probably they were not there because it is introduced in last 1.5 years. People with intermediate care are many people and people with minimal care are there. But there is a missing prevalence, and missing prevalence of non-diagnosed are many in our country. Now, the person who is having diabetes below the age of 10, he can have the normal life up to the age of 28.7 years. This is roughly the mean age of healthy life if a person is diagnosed with type 1 diabetes below the age of 10. Otherwise, if he does not have diabetes, normally that child should survive up to the age of 73.5 years. So the Indian average life expectancy at the age of 10, someone should survive up to the age of 73.5 years, but that child will not have healthy life of 44.8 years. That's a median age of 44.8 years. That life will be lost. Either the child will have a premature mortality or he will have a lot of complication in form of different disabilities or complication like kidney failure or nephropathy. And they will, most of them by the age of 40s, in early 40s, they will not survive if they have developed the end-stage renal disease or they have developed the other complication of type 1 diabetes. So actually type 1 is still these healthy years of the life, which is almost 45 years for a type 1 diabetes who is developing below the age of 10. How we get are these numbers. This is what they try to explain, the JDRF in this particular paper, that how they are coming out with this number, this type 1 diabetes index. They have a model which simulates each country each year to build up a view of how many are living with type 1 diabetes and how well they are. How many new cases are added, people living with type 1 diabetes, and what happens to them for a complication and death. Some of the data which are published from those countries, accordingly, they had got these numbers. And I'm sure Professor Ramchandran and Dr. V. Mohan, they knows much more about that, how to calculate these numbers. There are some universal challenges for type 1 diabetes. Type 1 diabetes means they have a lot of challenges, which is related to their nutrition, which may be related to their stress, that may be related to their family, that may be related to school, that may be related to traveling, that may be related to monitoring. These challenges are universal. Whether the sick days are there, if child is born in Germany or India, both of them can have a sick days. But challenges, some of them are unique for India. One of the very important unique challenge for India is disproportionate medical burden of type 1 diabetes. These type 1 children, which are very high in number, but still in compared to type 2 diabetes, their voice is completely submerged. More years of type 1 diabetes, because the child is developing diabetes at the age of 10, 12 or 15, and the lifestyle has to be completely changed. And the regime is also complicated, because we ask them for 4 times, 5 times to check the sugar. They have to take 4 to 5 times a short-acting insulin, 1 time a long-acting insulin. They are dependent on the parents. The parents are not having type 1 diabetes. The child is having type 1. So to teach or educate that caregiver is again becomes extremely difficult, because that person thinking that how a child will do these times, how many times monitoring, whether the child will able to take the injection or not. And largely the patient has to put out of pocket expenses. Even more than 100 foundation and many of the doctors like me, Dr. V. Mohan, even Vijay Shah and Dr. Ramchandran and many other foundations are providing some of these children even free insulin, free glucose meter, free consultation, but still the number is large. Poor infrastructure. We don't have that facility. Many of the government hospital and even the public hospital or the trust hospital, many of the endocrine center, they don't have the dedicated facility to treat type 1 diabetes. Health system at the public system, yes, it is improving, but there is no dedicated system, even in a pediatric department, in a medicine department, even in endocrine department. In some of the endocrine, they are training endocrine, postgraduate super specialty, still they don't have dedicated type 1 clinic. Very demanding in terms of medical attention. The children, the family, they all have to have, all the times they have to understand it so well that it is really very demanding, and training of healthcare professionals or trained healthcare professionals are not available. Even we have few endocrinologists, few diabetologists who are trained, but they are not willing to take care of these type 1 diabetes patients because they are poor, they can't afford to go them, and they are charging also. So that's again a challenge for those who are trained, and those who are not trained, they are not very trained healthcare professionals which are available. We all know about DCCT trial, and I'm sure all those who passed their MDs in 90s or 2000, we all know that how DCCT talked about that an intensive control of diabetes can reduce significant complication. And it was in type 1 diabetes, which is a DCCT trial. We all know that intensive control can lead to significant complication reduction. But the problem is with the persons who are developing a lot of hypoglycemia. By intensive controlling the sugar, they develop a lot of hypoglycemia. Even in DCCT trial, there was 60 per 1,000 year, the 60 per 100 patients here were actually developing hypoglycemia, and that was a limiting factor for these patients to have intensive control for diabetes. So managing type 1 diabetes is like walking on a tightrope. One side there is a hypoglycemia, other side there is a hyperglycemia. And hyperglycemia have a long-term complication, and hypoglycemia have immediate problem of psychosocial, financial, and some of them have even morbidity because they get hospitalization, and the even mortality can also happen. The other problem is accepting diabetes itself become extremely difficult. It's not easy. Today I have seen a patient, even after 1 month of a type 1 diabetes diagnosis, had gone to 5 different specialists, from primary care to a pediatrician to a physician or one endocrinologist. Patient had come from somebody near Jodhpur from Rajasthan, and patient family is not accepting that my child is having diabetes. They have a diabetes denial. They have a fear that no, it is not the diabetes, and they go in depression. They don't want to check the sugar. They don't want to see that sugar is report is whether it is coming normal or not, and they don't want to give the insulin also properly. They want to reduce the dose, constantly thinking the child will get cure of diabetes also. This one example in 2011, which was published actually in one of the magazine, and this is the Cara Newman case, was an incident in which a parents of a sick child, they refused to treat her with anything other than prayer. And this is from the Western world, resulting in child death. So you can understand, even in any part of the world, people may think that child will get cured by just going and doing the prayer, and they don't want to treat the child, and they depend on the parents. So you have to educate the caregivers more sometimes than the child. That is what is required, and you may lose many of your patients just because they don't want to get the treatment, or they go to an alternate therapy. It is very demanding, as I told you, in a medical attention, even very demanding for the patient and family. And at the same time, I will say it's very, very demanding. Those physicians, those diabetologists, and those endocrinologists who are treating type 1 diabetes, they can understand that how demanding it is in terms of medical attention also. As I told you, we have a poor infrastructure. But the poor infrastructure is not only in the public health system, even it is in private health system also, because we don't give the access to them a free insulin. Even the free insulin where it is available in public health system, some of the state government had started giving, but there is no consistency. No consistency in the same type of insulin. Sometimes insulin is prescribed, and the pharmacist of a public health system, they are giving the insulin which could be premixed, which could be any insulin, and they are not given sometimes a long-acting insulin. Patient is only on short-acting insulin, and they develop recurrent diabetic ketoacidosis. Sometimes they take this short-acting insulin with 100 IU per syringe, or sometimes they are taking only this insulin midnight, also a short-acting insulin, and they develop a lot of hypoglycemia also. We don't have that much sufficient fund from the government side to take these patients' care regularly. Patients and their caregiver and primary care physicians also sometimes feel that sugar cannot be controlled effectively because they have tried some of these things, which is not very scientific way of treating type 1 diabetes. So sometimes from doctors to patients as well as caregiver, they all feel that type 1 diabetes cannot be taken care, and we can't keep their sugar under good control, because one side, when they try to increase the dose of insulin, they find more of hypoglycemia. Other side, they always have the HbA1c of more than 10. One very interesting sentence which is written by DCCT chairman in 1980 to 1993, that DCCT was done, that intensive diabetes treatment is not just more insulin. And this is a common mistake done by a primary care physicians, pediatrician, as well as many of our healthcare professionals. If patient sugar is not getting control or HbA1c is high, whatever amount of insulin patient is taking, they just try to increase the dose by 1 or 2 units or 5 units at randomly. They just don't take the history completely. They just don't monitor it multiple times. And just by increasing the dose of insulin, rather you are increasing the risk of hypoglycemia. You are not achieving a tighter glycemic control. So you have to find when the sugar is high, when the sugar is low, when the sugar is actually graph. It does not mean that all patients should be on CGM because they can't afford, but definitely multiple times monitoring will help, and then you intensify the therapy, not just by increasing the dose of insulin. Diabetes management for a type 1 is like 4/7. It's a constant juggling between insulin and medication, the exercise, the food intake, the carb counting. So it requires a lot of things. So a patient may come to a doctor only for once in 3 months, once in 6 months, and sometimes to specialize like Dr. V. Mohan, or to a center like a dedicated center for type 1, maybe once in a year. But management for these type 1 diabetes is, other than hospital or clinic, is 24/7. So out of 365 days, whatever we are teaching, we have to teach them that how they have to live for these 365 days. And with broad range of activities, because that child may be doing a lot of sports activity, physical activities, their diet may change from weekdays to weekends. They might be eating in a school something different, and while they are in a holiday, eating differently. The individuals are always in need of support. So we have to create a support system also for social worker with our diabetic educator. We have to educate sometimes the family, more schools, the peers, the society. And there is a lot of awareness is to be required, but we have low level of awareness which is seen in patients as well as in caregivers. This paper which we have written with some of us along with Dr. Vijay Vishwanathan is also part of it. From the CDIC, all those centers who are taking care of these CDIC children, Dr. Prasanna Kumar and myself, a type 1 diabetes awareness, management and challenges. The current scenario in country, it's slightly old paper, but the idea was that what is the status of awareness in our country and what are the different challenges which we have. And one of the important challenge which we found, there is an overburdened healthcare system. Even some of the centers, even if I see my center also, we see a lot of type 2 diabetic patients also, like we see 50, 60 patients per day. So unless you have a dedicated type 1 department, unless you have a dedicated type 1 educator, nutritionist, and some doctor who are taking care only type 1. So we see only 5 patients in a day for type 1, but we see 60 patients of type 2. But 5 patients requires full day. It means almost a half a day new case comes, it takes almost full day. Then other patients also require more than 3 hours of education, teaching them, educating them, multiple things. So overburdened healthcare system is also one of the problems and a big challenge. Even some of the centers who have dedicated, if they don't have dedicated type 1 department, the overburdened healthcare system will not able to take care of these type 1 children. Just by giving them a 10 minutes or increasing or decreasing their dose will not improve their care for diabetes. There is one more big problem is alternative medicine. We have quacks in our country. They talk about cure for diabetes. They talk about cure for type 2. We talk about cure for type 1. They have put their on social media video. The Babas are talking that type 1 diabetes can be cured. Even we have written to the government, to the a white paper has been given to the health minister also to talking about that type 1 cannot be cured. You understand that what exactly type 1, and if you stop their medication, they will develop diabetic ketoacidosis. We celebrate this World Diabetes Day is on Dr. Benting, who discovered the insulin. Without insulin, before 100 years, they all were dying. So this also we have to talk to the society and we teach and educate and increase the awareness. Please don't talk about the alternative medicine or stopping the insulin for type 1 diabetes. Trained healthcare professional constantly, even we are trying for them to healthcare professional are to be trained. But one biggest thing which we are trying since last 20 years, please don't try to premix insulin. That will not work because the premix insulin is only a way by which you can keep the child just to survive. Patient will not develop hypoglycemia because you are giving a small dose. Patient will not develop diabetic ketoacidosis. So a pediatrician or a primary healthcare professional, neither he will get a call nor for a hypoglycemia nor for even for a severe hyperglycemia also. But most of time the HbA1c of these patients will be more than 9, and they don't want to spend more time to get themselves educated, and neither they want to educate their patient also. So I always tell that these healthcare professionals, if you are too busy, if you are not able to take care of these type 1, please refer them at the right center. That's very important. At least send them for education. That's more important. And using and accepting the newer technology. That's very, very important because we are otherwise very techno savvy. We all are using this online platform to learn. We are using the mobiles. We are using all those gadgets, which are one of the highest in the world, but still probably accepting the technology for healthcare system is poor. Out of them, in diabetes, it is less used, and even it is less used for type 1 diabetes also. How does India compare? The same type 1 diabetes index paper. If I see this paper, again, you will find that India actually looking like a Sudan. Our child who is developing at the age of 10 will have normal life only up to the age of 28.5. And you will be surprised, even someone who develops type 1 diabetes, a country like Sudan, which is underdeveloped, still he can survive up to the age of 23 if whatever amount of insulin and whatever type of insulin is given. As we know that first 10 to 15 years, many of our type 1 diabetes, if you just give them insulin, they will survive and they will not develop complication. But we are not near to somewhere the country which are developed like UK, France, Germany, United States, even Brazil and Russia. which is like developing countries like India. We are part of the BRICS, which is Brazil and Russia is a part of that. Still, we are not near to them. We are surviving. Our child who is developing below the age of 10 will not survive more than 28.5, while the child who is born in Brazil or Russia, at least they will have normal healthy life up to the age of 45. Why does India look like this? What is the solution? Probably the 10% of our patients who are not diagnosed at the right time. So they are diagnosed late, and probably they are not diagnosed before then they die, or some of them they reach hospital so late that even for treating them, and the treatment of diabetic ketoacidosis, which is a very basic treatment, nothing more is changed in last 25 years. But still, many of the primary care physicians are treating them and giving them more insulin or giving them more fluid and developing brain edema and cerebral edema, and they die also. So that may be one of the reasons for them. Some of them are treated, many of them are 80% of the cases still in India are treated with pre-mixed insulin, and they don't taste it. They don't check the sugar. They just take 2 times insulin and they keep on taking these insulin. After 15, 18 years, when they develop complication. In childhood, they have started this medication. At the age of 20, 25, or 18 or 15 older, they go to adult diabetologist when they have already developed the complication. So when they come to us, they have already nephropathy, they have already retinopathy, and they have sometimes so severe. Now, whatever best you do, they are going to develop the end-stage kidney disease. So if we just change this system or educate them, probably we can improve their quality of life. We can give them better survival. We can give them a complication free up to the age of 54. So it's not necessarily that all the children should be given the pump and CGM, as we know that we can't afford for each and every type 1. But if we can afford for all these children the basic basal and bolus insulin, we can give them a glucose strip to check 4 times sugar in a day. And what is more important is self-management and education. If we educate all these children and caregiver, probably we can give them a life for up to the age of 54, which can be complication free. Now, how we can do? It is going to increase the cost. And definitely, even if we give them basal bolus, if we give them a 4 times sugar to be monitored, it is going to increase the cost at least by $2 per day, or maybe $1 per day in our country, if we can get them from some government hospital and some supply at a reduced price. Still, it is going to increase the cost. But this cost, I think now India can afford. It requires more of a education. It requires more of a education of professional, healthcare professional. It requires more of a education of caregivers also. So type 1 diabetes, I always say the management is not just insulin. A simple insulin supply will not improve their care. When before almost 20 years or 15 years before, when we started CDIC, we thought of just giving insulin, but alone insulin was not sufficient to improve their care. When we started educating them more, we found that their sugar started decreasing. Their A1C, which we started with 9.5 and 10, it started decreasing by 9, 8.5, and now it is roughly, most of the centers are having average HbA1c of around 8 or 8.5. Some of the things which we don't talk to the patient about, the insulin syringe, we don't talk about the cold chain, the U40 and U100 vials and pen fills, which is very, very important. Sometimes communication become extremely difficult because patients might be coming from the different parts of the country also, and that requires the local language. Some of the tertiary centers, like the centers of Dr. V. Mohan, Vijay Vishwanathan and Ramchandran, they might be getting the patient from even Assam and from Northeast and from North India also, and they may have a difficulty for communication too. The glucose testing require more education, because unless you educate them, they are not going to do 3 to 5 times in a day. The disposables of sharps, handling acute complication, regular medical review, these are also requires a lot of education. We have to educate them for chronic complication to be tested. Sometimes we have to teach them every year, almost like for thyroid. You have to suspect for the celiac disease also. It's not like that we have very low incidence, so don't do for all these things, because that's very important. That some of the patient, their sugar will improve as soon as you find that they are given the gluten-free diet, and their growth and development, everything improves also. The SPAD recognized us when I became the part of SPAD in 2011 to 2013 as their executive committee member. And we talked that how India, what type of type 1 diabetes care which we are giving and what type of type 1 diabetes care we want to give. And in India, we started talking about the SPAD clinical practice recommendation guideline after 2011. And they included me in 2014 also in their guideline. And then now consistently after 2014 to 2023, more than 20 experts from India are part of SPAD clinical practice recommendation and guideline. Despite multiple advances, there are many barriers for type 1 diabetes in the life of type 1 diabetes, particularly in India. One of the important problem which I talked about, the lack of awareness. Even we have a lot of advances, but still the awareness at the level of society, at the community level is very, very low. The poverty, as we talk, but lack of resources. Because once they are not aware, they don't know the resources also. Even some of the children, they don't know that insulin is freely available in some of the government hospital. These parents are not knowing that some of the foundations are not only providing you insulin glucose meter, but they also provide a lot of education also. Sometimes the problem of distance to clinic, even you are providing at Ahmedabad or at Chennai, but the child or the parents has to travel from 300 kilometers away to get the insulin. And that also is very costly for them as a transport also. There is a poor understanding of childhood diabetes. Many of these doctors, many of the pediatricians are also not understanding the childhood diabetes or pediatric diabetes. And sometimes they feel that adult physician, once these children who are type 1 diabetes diagnosed in a young age, when they have reached at the age of 20, 25, go to physician feel now they can be given the tablets. Now there is no more requirement of insulin also. So that sort of a poor understanding is there. Still in our country, there is a weak healthcare system and the lack of awareness and cultural misunderstanding and a lot of stigma is there with someone to have a type 1 diabetes. This type 1 diabetes network during my presidency in 2018, 19 and 20, we started a mission to build a positive ecosystem for a type 1 diabetes care plan, pan-India to the last mile. For the child who is even in the rural area, must get the best of the best treatment. We are trying to manage these barriers by continuously educating our healthcare providers, free insulin and glucose meters to needy patients. We have tied up with many international organizations like CDIC, LFAC, RSSDI had tied up for a type 1 diabetes project. We have established type 1 diabetes network. We have young leaders group all across the country. A tie-up program which we have done with a UK endocrinologist educating our Indian doctors for type 1 diabetes. We have created modules for educating caregivers and a persons with type 1 diabetes and more than 100 foundations which are there in our country to support and to educate all these type 1 diabetes. On 9th and 10th of this month of December, we are going to have a type 1 diabetes conclave where we are inviting all these foundations and many of the experts in the field of type 1 diabetes to come at the Aurangabad at the center of India, where we are going to have this conclave for 2 days. I have written one more paper about a type 1 diabetes registry. We don't have a dedicated registry. As I become the part of SPAD, we have become the part of SWEET registry. That's an international registry. Primarily, it was only in the Europe. My center was the first non-European center of a type 1 diabetes registry, the SWEET registry. And then in India, more than 50 centers. And now in Asia, another 50 centers have become part of this SWEET registry. And I am the hub leader for Asian countries for this type 1 diabetes registry. So I think probably by making registry in developing countries will also improve the care for these type 1, because we will able to know that how these type 1 longitudinally, how they are behaving when they develop complication and what happens to them. We all understand the importance of monitoring in type 1 diabetes. But one I just want to give you again, in 1983, the DCCT trial, when they were doing 4 to 5 times sugar monitoring and tried to keep the HbA1c less than 7. But the mean A1c, which they could have from 9 to 7.2, at the risk of developing hypoglycemia, 62 per 100 patient year. And this was in DCCT trial. in Juvenile Diabetic Research Foundation, one more trial they have done, similar type of patients, but more of adult patients. They had provided continuous glucose monitoring. And you can see the mean A1C of these patients from 7.6 to 7.1. They could achieve their HbA1c, the mean A1C of 7.6 to 7.1, and the severe hypoglycemia, which was 762, which is decreased significantly from 62 to 20 per 100 patients here. So you can understand the importance of continuous glucose monitoring, how it can help instead of putting them on a multiple time random blood glucose monitoring. One more example, that cesium had become now almost universal in UK population. If anyone in type 1 diabetes, UK, because of Partha, who is one of the advocacy, who is doing a lot of advocacy for providing continuous glucose monitoring to all type 1. And almost all type 1 in UK, now they are given continuous glucose monitoring. But despite continuous glucose monitoring, the 70% of the patients are not achieving tight glycemic control. So I am giving you two different data. One, I talked about the data, which is talking that yes, they are developing a better control, but still they develop hypoglycemia, which is 20, which is much less in compared to the people who are doing random blood glucose monitoring. And then I am giving a data, recent data published from UK, that they are providing all patients CGM, but less than 7 is only achieved in less than 70% of the patients. So it means they need more. It's not just CGM is alone is sufficient. And why it is so? If I take one patient and doing his continuous glucose monitoring, you will be surprised that 4 days, the early in the morning, a different type of glucose pattern is coming. Same patient. One day, the sugar is started with a high post-meal, post-dinner, and then early in the morning or late night, sugar is getting almost normal. The other day, the overnight sugar was okay, but early morning sugar was high. The other day, the patient actually midnight sugar had gone low, and then early morning there was sugar was high. And the other day, fourth day, patient full night the sugar was low. So now you can understand these four different type of, one patient with four different type of glucose profile. What will you do? Will you increase the dose of long acting? Will you, because one day he's getting hypo also? Will you increase the early morning, something which is insulin is to be given at 5 o'clock, you want to give a short acting? Or will you give the late night a short acting more? You can't do anything, because seeing the four reports, you will find that if I increase any of these insulin, patient is going to develop more of a hypoglycemia, sugar is not going to develop, getting control. So there is a significant intra-patient variability is there. If 4 nights in a single week, that possibility is there. And that's the reason we need something more, not just simple continuous glucose monitoring. So insulin pump therapy is actually boon for type 1 diabetes. It's just not only for changing different type of basal. The same patient, I can put him on a different basal time on a different day, or the same time, I can put in multiple bolus also. If patient is doing continuous glucose monitoring, he can take this correction dose multiple times in a day. And that is possible by putting the patient on an insulin pump. A patient who is on insulin pump, even they can take 7 or 8 bolus in a day, and they can also decide their basal dose in a different times of the day, different basal, maybe 6, 7, 8 different times of basal also can be given by insulin pump therapy. We have written some of the papers on insulin pump from India also. Jyoti Dev, also myself also, we have written. There are some issues in India. One of the important issues is definitely cost, but the practical problem is, other than cost, is an education about the insulin pump therapy in our country. Those patients who can't afford the insulin pump therapy, some of my patients to whom we have put them do it yourself. So you are using a older pump and you are using a Libre, and still you can do it yourself. You can put these two pump, these two system of doing a continuous glucose monitoring and an older pump, still you can make it like a sensor augmented pump therapy, or like a new insulin pump which is available to our country, 780Z, which is advanced hybrid closed loop system. That sort of you can do it yourself in an artificial pancreas. So the broad components of a type 1 diabetes management is a early diagnosis, lot of awareness, access to quality care. That includes not just access to the insulin or glucose meter. It requires complete care. It requires a stable, affordable insulin and a long-term monitoring, a lifelong. a self-management and a very, very structured education program, which we have to give to the patient and to the caregiver. The few statistics which we cannot ignore. I am completely the advanced hybrid closed loop system, because primarily largely I'm talking about type 1 diabetes care in our country. So some of the statistics which we cannot change for our type 1 diabetes, like 4 injection per day is minimum for all our type 1 children who are developing diabetes below the age of 10. For another 50, 60, 70, 80 years till they live, they have to take it. If someone develops in the early adulthood, they also have to live for another 50, 60 years, they have to take. Some of the things like diet, exercise, hormonal changes, sickness, exams, traveling, stress, rejection, they all can affect the blood glucose level. So a type 1 can have multiple such fluctuation, and that they have to accept, the caregiver has to accept, and healthcare professional has to accept. Blood glucose measurement minimum 1 to 7 times, and I always tell all my patients minimum 4 times, and they have to do up to 7 and 8 times. And many of my patients, they do every day 4 times, and once in a week or twice in a week, at least 7 to 8 times in a day, to know their complete glycemic profile. As a doctor, as a healthcare professional, as a diabetologist, our role begins as a healthcare professional, as a coach. We are not the player. Player is that child. Player is that type 1 person who is having diabetes. We have to continue as a friend, who have to support these children to have a healthy life. To conclude my talk, to summarize my talk, treating type 1 diabetes is a challenging task in India due to vast difference in socio-economic status of patients, educational backgrounds, and availability of diabetes care. There is a distinct need for a comprehensive diabetes care program to improve care for type 1 diabetic patients. The essential diabetes care, including insulin and education, should be universally accessible in terms of technology, expertise to the general population, and it should be acceptable to them at a very, very affordable cost. A multidisciplinary team approach is required to overcome the challenges in managing type 1 diabetes, and this may help to improve their glycemic control to reduce the complication. Thank you. Thank you very much. But before I give thanks, we want to give talk after 10 years and 20 years and not showing the data of type 1 index that, our children are living only up to the age of 28. We have to show our data, and we have to change this story that our children are going to live the normal, healthy life. So after 10 years or 20 years, probably we will be talking again that now our children are not like what the Sudan child is going to have. Our child is going to have a normal life like someone is living in a Germany or in USA. We have a lot of collaborators across the world from Diabetes India, RSSGI, and SPAD. I want to thank each one of you who have participated in this meeting, and also thanking Life for Child and CDIC for supporting many of my children who are supported from LFAC and CDIC to give them free insulin. Once again, thank you, sir, for giving me this wonderful opportunity and to talk in front of you. Thank you. Thank you very much.
We have around 5 to 10 minutes before we end. We have 2 doyens in the field of diabetology of more than 40 years experience, Dr. A. Ramchandran, Dr. V. Mohan. And I would like to just ask one question to each of you. I'll start with Dr. A. Ramchandran. What is the biggest challenge you have faced in treating type 1 diabetes? You're muted.
You have to unmute. You have to unmute.
No.
Okay, I think one thing, very good talk, and we have covered almost the whole thing about everything about it. And the question that Vijay is asking is the greatest challenge. I think the cost of illness is an important issue, because it is not only the cost of insulin, it is also cost of the meter and the strip, which is very expensive in this country. The average income of our people in villages is pretty low, and the amount of money that is spent on a child with diabetes is almost from the family income is pretty high, 25 to 30%. That is going to be one of the greatest barriers for taking care of children with diabetes. That is the first thing that is a barrier in the population, because at this point of time, free insulin cannot be provided for all the children who are diabetic. as you rightly said. So the cost of illness, sustained life, is a barrier for the whole country. So we cannot expect that everybody can be treated from out of pocket because they do not have the money. So sometimes it's very cruel. Death of a child takes away the expense of that child's family. That happens. The second thing that here is significant is that your work. I just want to give an anecdote. Mohan was a student and I was in BM out of Viswanathan's clinic. This is 45 years ago. And that was one of the things I still remember because that is one of the very powerful things I saw in a type 1 diabetes. This is a girl who was suffering from taking treatment. And she was actually a Marwadi. She got married. She did not tell the in-laws about her diabetes. And she stopped insulin completely. She went for honeymoon to Uti, and then did not take insulin at all for the next 5 days. Absolutely started vomiting, became unconscious. She was brought to our hospital. I still remember it was almost midnight, I think morning. Yeah. And she was unconscious. And I thought, and they gave a history that she got married about 5 days ago and she stopped it. I'm talking about in the 1978 or 1981. And she died. She died. How can you not forget about this? And this must be happening even today.
Yeah.
In India. So lots of illness and the stigma that now can the big issue. And so I'm very happy that you have covered both.
Okay,
thank you. Thank you, Dr. Ramchandran. I think that case I have written about in the Banting Bose and beyond. Actually, the husband came and dumped the child, lady, and said, because he asked who's a doctor. And when they said it was MB Hospital, Roypuram, they brought, dumped the child, and he left and he never saw her again. That was the end of her. So how many times we told them, please don't hide, and they still hid. And that finally the girl just got married. If she had not got married, she could have just stayed like that. And in their community, nobody will marry again. So it's a very powerful case, and I've written about that in Banting Bose and beyond. Now, one of the points which, Banshi, you touched on so many aspects of type 1 diabetes, but while agreeing that cost is a major factor, and it's definitely one of the major factors. For example, you talked about 780G, and 780G is a fantastic tool. There's absolutely no doubt about it. But how many people can afford it, and who's going to give it? Is government going to give it? Now, the Tamil Nadu government has finally decided to give 10 pumps, old pumps, to children. That's what they're going to do. 10. More than 10, I am giving free. Now, the whole government is giving 10. Okay, they should be giving 3,000 or 5,000 children, but they're giving 10. That to the old pump. And in Kerala, they announced that for 300 children, they're going to give. Finally, they gave 10 or 6 or something. It's in single digits, I think. And so even governments are not taking part. But I'm not coming to that. See, for example, we have got, a foundation supporting us, as you know. Several hundred children are being treated. So we give free AGPs, we give CGMs, we give pumps to some people, we give insulin free, consultations are free, checkups are free, complication checkup is free, everything is free. The child doesn't have to pay even 1 rupee. Despite that, about 1/3 of the children are not maintaining good control. Everything you can give in a private center, which they'll have to pay thousands of rupees, we're giving it free. Our people are in touch with them. Still, they are not able to get their A1C under control. So we have been actually grappling with this. Why is this so? We've given everything to the child. Why is that the child is still not able to? Then we found that psychological factors, and Dr. Yajnik will also agree with this because he's also part of this. So psychological factors are very, very, very important. And very often, they don't relate to us because they've directly asked me, do you have diabetes? No. Do you have type 1 diabetes? No. Then you will not understand, doctor, the pain that we go through. They don't consider us as part of them. But they say you don't have type 1 diabetes, so you will not be able to understand. Mentally itself, they're blocking out. Whereas what we have found is if we get a peer, a type 1 diabetes older person who got it when they were a child, and now 20 years old or 30 years old or 40 years old, already lived for 30, 40 years. If they come and they say, I got it when I was 5 years old, I'm 45 years old, 50 years old. I've taken 4 times a day insulin. Immediately everybody's waking up and they're, oh, you had it for 40 years, you took insulin. So I think that fear thing is something which we can use, and psychological help is what they need. In a state like Tamil Nadu where insulin is given free, you read that horrible incident where that child, first girl developed, is near Salem, I think, Namakkal or somewhere, where first girl developed type 1 diabetes, and then the second girl developed type 1 diabetes, and everything is given free. In the government hospital, insulin, syringes, everything is given free. This happened last year. The family took both the children, threw them in the river. They also jumped into the river, and all 4 committed suicide. Now, this is happening in India, in Tamil Nadu, which has one of the best healthcare systems in the whole country. Probably Tamil Nadu and Kerala have the best. There it has happened. And I said, it's complete failure. What are people like Ramchandran or me or Vijay or you or anyone or the government doing if this is happening in our country? We feel very, very sad that this is happening. That means psychological support has not been given. They're given insulin, they're given syringes, they're given everything, but they didn't tell them, look, your child is going to be fine. We are going to look after it. The child is going to be a healthy child. That is what I think is very much needed. I'll stop there.
Sir, I fully agree with you. And I talked about the peer support. You and me also tried to involve all these type 1 diabetes foundation, juvenile parent education foundation. I am supporting in Gujarat more than 10, 12 centers, also such foundation too. And they really support, there is no doubt about it. In my clinic, we have 3 type 1 children. One of them is on pump, other is using continuous CGM monitoring, and other is a random glucose monitoring. So one of them is an educator, one of them is a social worker, and other is nutritionist, and they all 3 are working only for type 1 diabetes. So they give the peer support, there is no doubt. But there is some other problem also. These foundations, you and me have supported them more, and now they have become like an independent clinic.
They have become diabetologists.
They had also started asking the free insulin supply from the government. They are also asking all those benefits of LFSC and CDIC and all those things. So they had become
treating also. They're actually treating.
Yes, and they started, because in India, anyone can write anything, and that's the problem, because they can get without a doctor prescription also the therapy. The other challenge is, even you patient write the best of the best pump therapy. Now the older pump, that all those patients to whom you put on older pump, their sugar is not getting good control, because they don't come back to you. They don't come back for the even prescription. The Medtronic people will keep on supplying them the disposable, and that people will develop all sort of complication. Now, thanks to this 780G, at least it has got its own automated system that, the patient sugar at least will remain under control. And we ask them very specifically, please ask the patient to come back to your clinic once in a year, if not coming regularly for 3 months to know their time in drain. So I'm sure in future it will improve, but I fully agree we all see different similar type of patient and cases all across the country, but still the education of doctors, and that is, I think it is in our hand. If a primary healthcare physicians or the pediatrician to whom we can educate, and that is what RSSJ is doing, and continuously in last 5 years, 10 years, you can see that now type 1 diabetes and related to type 1 diabetes is in main hall. It is like talked not like a workshop or somewhere where it is not been talked. Now we are talking in full-fledged symposia we are keeping in our program. So that much we are trying. And thousands of doctors in India started taking interest in type 1 diabetes, at least when we talk about type 1 diabetes. That much I can say. In this meeting, more than 300 doctors are coming in Aurangabad. We will miss you, sir. Actually,
I know I'm traveling and got something else on that day.
And Aurangabad is again a difficult place to travel also.
That's very problem.
From Chennai also.
Vijay, any questions are there?
There's one question. Then only we'll finish in 5 minutes.
Yeah.
The first thing is, the biggest challenge I face is taking insulin in the school. They skip the afternoon dose, and no amount of insulin given in the morning covers the afternoon meals. And by the time they come back home, the sugars are very high. So glycemic variability is very high. The one question from Dr. Killi Valavan, who's a diabetologist from Tanjavur, I think. So his question is, should you be checking the siblings of type 1 diabetes? Banshi, question.
First I am answering the second question. Siblings of type 1 diabetes, if I want to check just for the sake of whether they are autoantibody positive, and if I can afford to give them a therapy for prevention of type 1 diabetes. I think at this point of time, India is not mature enough, neither from financially, nor we are capable of doing all those patients for their autoantibody. And then it is also required, because this year in SPAD, the keynote lecture was for preventing type 1 diabetes. And you know that it's how difficult that every 3 yearly they have to do their autoantibody. At least before the age of 12, 3 times they have to check if your sibling is between the age of 1 to 3. Again, between, if that time negative, again you check between 6 to 8, and again in the before the age of 11 to 12 or 13, 3 times you have to check minimum. And if they found positive, then you have to think of giving them a monoclonal antibody. So that's very difficult. The second question which you had asked about the insulin injection in the school, and that's really a very challenging. So 2 things I do. One is we write a prescription for weekends and weekdays both, because Monday to Friday and Saturday, Sunday, they will be different, because that time they will be checking. Now, Monday to Friday, when the child is going in school, and if child is not checking the sugar and the food they are consuming in the school, and which leads to the increase in glucose when the child returns home, and pre-meal sugar is very high. One thing, you completely change the tiffin box of that child, that if child is not checking, and at least you can say that consume minimum amount of carb in the school when the child is not taking extra amount of the insulin. But the best solution is do the injection, give the injection, teach the school teacher, teach the other school children also. There is a dedicated program of knowing diabetes in school. That's a kids program, which we are talking about the insulin therapy for type 1 diabetes children, as well as we talk about the pediatric obesity, which is a IDF and SPAD supported, and internationally it is supported by Sanofi. If any doctor in India is interested to do a program in any school, they can get the support. They can download all the material from the website, and even the local company representative will also support them for conducting this school program also. So this much we can do, but yes, still it is a very practical question. And many of our school going children, they don't take insulin, and their sugar glycemic variability is very high. Yes, sir.
Thank you. Thank you, Dr.
Just a quick comment about that siblings thing. Earlier, we were not keen at all to check for siblings, because what are you going to do after you find out? It's like doing BRCA testing for breast cancer. If you get the gene, then when are you going to get cancer? You will be worrying all the time. Better not to know certain things. Like, for example, if we all know when you're going to die, suppose we know tomorrow we're going to die. What's the point in knowing? Better we die, no? Rather than you know you're going to die tomorrow, then from today itself, it's not tomorrow I'm dying. So it's like that. If you get BRCA testing done for breast cancer, it's like, or like Angelina Jolie, you'll have to remove both the breasts, and so that is also not practical. Now, in type 1 diabetes, you're not testing, because they'll say, oh, no, one itself is enough. Now, I don't want to even hear that the other child. Today, an ethical issue has come, because teplizumab has come. Now, not testing siblings when there is something available is a problem. Now, if you test 8 to 10% of the siblings will have type 1 diabetes at various stages, stage 1 or stage 2 or whatever. Now, the problem is, once you diagnose and you have GAD antibody positive, the GAD antibody testing somehow we can do. The cost of those 14 injections of teplizumab is 1.5 crores for one child. 1.5 crores. Okay, 1.5 crores can give insulin to how many children we can give. So, unless a cheaper monoclonal antibody is produced in India, this testing is going to be a problem, because even if you test, we don't know what to do. Of course, whether verapamil can be used is something we'll have to see. But it's constantly in my mind. Other countries are doing it. Why in India? Because if you diagnose and give that child something, C-peptide will go up and they won't die of DKA. You talked about the disappearing child. That's because of DKA and they're dying. That's something we have to do, but it's not something which you can discuss here. But it's
at present, it is not practical for India. Italy government, first European country, had started doing for their children,
Australia,
but
Europe, US, Canada, all of
it, but they can afford. But for India, I don't think. The other child is not getting the premix insulin, and you are thinking of therapy of 1.5 crore. So that's not very practical.
One last question before we conclude. Can we use, from the chat box, can we use AGP for a 2-year-old child? It's a question asked by Ruben Chakravarti.
The Libre, which is Libre Pro, which you are talking in India, is not for pediatric use. The information which you may get may not be very accurate. Just to know about the glycemic profile or a glycemic variability, you may use, but officially off level you can use, but it is not officially to be prescribed for the patient. That is my, and if patient want, we can ask them that better insulin glucose continuous monitoring devices which are available and that can be used for pediatric use also. Yes, Dr.
Something else, that when a very small child is having diabetes, do not think of tight control of their food. What you want to do for small children below the age of 5 years is to just keep them out of the hospital, keep them out of diabetic ketoacidosis, avoid severe hypoglycemia. Let the blood sugar be 200 for 5 years. He's not going to get complications. This is an old dictum that we do not have tight control. We do not advocate tight control for small children. Our aim should be to keep them out of hospital without severe hypoglycemia. So don't think of using CGMS for a 2-year-old child. Just check the blood sugar minimum at least 2 or 3 times a day so that it doesn't. And then you give insulin. Keep the blood sugar sometime between 150 to 200. Maintain it that way. That's the practical thing for small children.
Yeah, so I think we can conclude now because it's dinner time. And we'd like to thank Dr. Banshi Sabu for sparing your valuable time, Professor A. Ramachandran and Professor V. Mohan for sparing your valuable time. I think we have answered all the questions. And we would like to step up the gas pedal for type 1 diabetes in India. The focus on type 1 diabetes is very less. So we request Diabetes India and RSSDA to step up the awareness on type 1 diabetes. And we have a world leader, Dr. Banshi Sabu, who gave the wonderful talk today, who's leading this Pad and Sweet Registry. Thank you, Banshi. Thank you.
Thank you. Good night. Be safe.
Bye. Thank you.
Bye-bye.
Bye.
Bye.